Hello and welcome to our webinar on exploring documentation for home dialysis. My name is Jennifer Boniface, and I am one of the registered nurses with the Provider Outreach and Education team. Today's webinar will cover the documentation requirements for CPT code 90966 home dialysis, including common denial reason codes associated with these claims. We will conclude by reviewing several claim examples to clarify the documentation needed to meet Medicare compliance standards. Home dialysis plays a critical role in the treatment of individuals with end-stage renal disease. CPT code 90966, which covers physician services for monthly outpatient home dialysis for these patients, is currently under targeted probe and educate review. This code represents the physician or practitioner's ongoing management, care coordination, and comprehensive assessment of home dialysis treatments monthly. It is essential for healthcare providers to maintain accurate documentation, ensure correct billing practices, and comply with relevant guidelines when delivering these services. Our objective for today is to discuss the required documentation to support claims for CPT code 90966 home dialysis, and we will review documentation requirements, explore common denial reason codes we encounter with home dialysis claims, and provide documentation examples related to CPT code 90966 home dialysis. So let's begin by briefly reviewing the provider visit requirements outlined in the Medicare Claims Processing Manual, Chapter 8, Section 140.1.1. Physicians and practitioners overseeing dialysis patients received a fixed monthly capitation payment. And this payment, also known as the MCP, is reported once a month for outpatient services related to the patient's end-stage renal disease. According to the Medicare guidelines, when billing for ESRD physician or practitioner services, a month is a calendar month. The first month of dialysis starts on the day the patient begins treatment and goes through the end of that month. For home dialysis, the MCP physician or practitioner is required to have at least one face-to-face visit with the patient every month, unless a waiver applies. This visit, which must be conducted by a physician, nurse practitioner, clinical nurse specialist, or physician assistant, should include a thorough clinical evaluation of the patient's vascular access site. So now let's discuss billing of MCP. According to the Medicare Claims Processing Manual, Chapter 8, Section 140.2.1, a physician or practitioner may, in certain circumstances, bill the appropriate age-based home dialysis monthly capitation payment even when services are provided for less than a full calendar month, as long as the CMS requirements for the monthly service are met. And these requirements include a complete monthly assessment and at least one face-to-face visit during that month. When those requirements are not met, or when a patient falls into certain CMS-defined partial month situations, ESRD-related services are generally billed on a per diem basis rather than using the full monthly MCP. CMS identifies several situations in which per diem billing may apply, include home dialysis patients receiving ESRD-related services for less than a full month, transient patients traveling away from the home for less than a month, patients who permanently change MCP physicians during the month, and certain partial month situations involving hospitalization, transplantation, or death when a complete assessment could not be completed. It's also important to understand that hospitalization by itself does not automatically determine whether the full monthly MCP rate or the per diem rate will apply. Instead, billing depends on whether the required monthly assessment and face-to-face services were completed and whether the patient's circumstances meet CMS's requirements for full month or per diem billing. And for example, if a patient is hospitalized for part of the month, but the physician still completes the required monthly assessment and at least one face-to-face outpatient visit, the patient may still qualify for the full monthly MCP. In short, a home dialysis patient can still qualify for the full monthly payment even during a shortened month of care, provided all CMS requirements are completed. Otherwise, ESRD-related services are typically billed on a per diem basis. The MCP physician or practitioner may delegate the responsibility of conducting some of the visits throughout the month to other physicians or qualified non-physician practitioners. The MCP physician or practitioner does not need to be present during these delegated visits. However, the individual performing the visits must either be a partner, an employee within the same group practice, or someone employed by the MCP physician or practitioner. And this includes W-2 employees and 1099 independent contractors. If another provider conducts some of the visits during the monthly capitation payment should be billed by the physician who is responsible for performing the comprehensive assessment, developing the care plan, and managing the patient's ongoing treatment. If a non-physician practitioner, such as the clinical nurse specialist, nurse practitioner, or physician assistant, conducts the complete assessment and establishes the plan of care, then the monthly capitation payment service should be billed under that practitioner's national provider identifier. Visits rendered by residents, interns, or fellows enrolled in an approved Medicare graduate medical education program may be included in the MCP visits as long as the teaching MCP physician is present during the visit. Now that we've covered the provider visit requirements, let's take a closer look at the main components that must be included in the documentation for the monthly face-to-face visit. These are essential to ensure your record is thorough and accurate. The first component is the dialysis method and frequency. Documentation should specify the type of dialysis the patient is undergoing, as well as how frequently the sessions are taking place. This is crucial for monitoring the patient's treatment plan and ensuring the care provided aligns with and meets their medical needs. Next, record the patient's response to and tolerance of the dialysis sessions. Document how the patient responds to dialysis treatments, including any complications, side effects, or discomfort they experience during or after the session. It is also important to monitor and track any changes in the patient's ability to tolerate dialysis over time. The third component is relevant laboratory results. Summarize all important lab results for the current month and, when applicable, compare them to data from the previous month. This includes tests such as blood work, electrolyte levels, kidney function, and other important indicators that reflect the patient's response to dialysis. Pay attention to any significant changes or patterns that may indicate a need to adjust the treatment or management plan. Finally, remember to include a signed note in the medical record for each face-to-face visit during the billing period to confirm the encounter. According to Medicare guidelines, a physician or practitioner is generally required to conduct a face-to-face visit with an end-stage renal disease patient before billing certain ESRD-related services to qualify for the monthly capitation payment. However, as stated in the Medicare Claims Processing Manual, Chapter 8, Section 140.1.1, Medicare contractors may choose to waive the face-to-face visit requirement for home dialysis MCP services on a case-by-case basis. For instance, this may apply when the nephrologist's notes confirm the physician has actively managed the patient's home dialysis care throughout the month. For patients who undergo home dialysis for the entire month, billing should be done using the appropriate HCPCS code for ESRD-related home dialysis services. The medical record should also include several additional elements of documentation. First is a signed order from the physician or qualified non-physician practitioner. This order must clearly specify the type of dialysis, its frequency, and any detailed instructions required to ensure the treatment is safe and effective when administered in a home environment. Additionally, documentation should include a complete assessment performed by the billing provider. This assessment, conducted by the physician or qualified non-physician practitioner, plays a key role in shaping the patient's care plan and supporting the management of ongoing treatment. The provider responsible for completing the assessment must also submit the claim for the monthly service. And as a reminder, only one monthly capitation payment can be reported per patient per calendar month. Next is documentation supporting that a full calendar month of services was delivered. The medical record must clearly demonstrate that all necessary services were delivered consistently throughout the month with no gaps or interruptions. Detailed documentation should be included for each service, ensuring it aligns with the patient's treatment plan and billing requirements. Specific service dates should be recorded to confirm the patient received continuous care as prescribed for the entire month. This documentation is crucial for maintaining compliance with regulatory requirements and ensuring accurate billing. Additionally, the documentation should verify that the dialysis facility is reviewing complete self-monitoring data and other relevant information from self-care patients or their designated caregivers at least every 2 months. Another element of documentation is evidence of patient training for home dialysis. This involves providing patients with the necessary education and guidance on how to safely perform dialysis at home, including setting up equipment, using proper techniques, troubleshooting, and following important safety measures. The documentation should also verify that the training was delivered by qualified personnel, ensuring that those conducting the training possess the appropriate credentials, experience, and expertise to teach the required procedures. This includes confirming that the staff are adequately trained to address all aspects of home dialysis. Furthermore, the documentation should clearly outline the staff's roles and qualifications to ensure the training meets regulatory and clinical standards. Lastly, the medical record should include a signed attestation statement or signature log for any missing or unclear signatures, as well as an advance beneficiary notice of non-coverage if applicable. So before we move on, I'd like to address a pre-submitted question we received. The question asks, could you provide more detail on what documentation should be included in the plan of care? Can the documentation come from multiple sources, such as social work and registered dietitian? For CPT code 90966, documentation for the plan of care should represent a comprehensive and current management plan for the patient's dialysis and overall medical needs. And this includes the dialysis prescription and modality, targeted dry weight and volume status, blood pressure management, and review of key laboratory values such as K/T, hemoglobin, phosphorus, calcium, and electrolytes. It should also include medication management, particularly for anemia and mineral bone disorder therapies, along with ongoing assessment of treatment adequacy and patient adherence. In addition, the plan should reflect patient education, care goals, and any changes in clinical management based on the patient's most recent status. This documentation may appropriately come from multiple members of the interdisciplinary ESRD team. For example, social work notes may address psychosocial status, barriers to care, and support systems. Registered dietitians provide nutrition assessments, dietary recommendations, and insight into lab trends related to diet. Nursing staff contribute dialysis treatment details along with day-to-day clinical observations. Input from each of these disciplines helps create a more complete and accurate picture of the patient's care needs. However, the billing provider is responsible for reviewing and integrating all interdisciplinary input, making clinical decisions, updating and maintaining the formal plan of care, and providing ongoing medical management. The final plan of care should clearly reflect the provider's active involvement and clinical oversight. And we'll look at examples of how these elements are documented when we review claim examples. Medicare allows telehealth services for home dialysis patients as long as certain conditions are met. According to the Bipartisan Budget Act of 2018 telehealth provision and the Social Security Act, Section 1881B3B, home dialysis patients opting for telehealth services for some ESRD clinical assessments must still receive a face-to-face visit by the provider without use of telehealth at least once a month during the initial 3 months of home dialysis and at least once every 3 consecutive months following the initial 3 months. Patients using telehealth for end-stage renal disease services are still required to undergo necessary lab tests and maintain contact with other members of the interdisciplinary care team. Providers should adhere to all face-to-face guidelines specified in the Medicare Benefit Policy Manual, Chapter 15, Section 270.4.1. Home dialysis patients may designate their home as the originating site for telehealth services. However, telehealth cannot be utilized if both the provider and the patient are physically present at the same location. Providers must also document the use of real-time audio and video communication technology in the patient's medical record when telehealth services are provided. And the link to that Medicare Benefit Policy Manual, Chapter 15, Section 270.4.1, can be found on the resources slide at the end of the presentation. Now let's discuss medical necessity. For a patient to qualify for this service, it must be considered medically necessary. This means the patient must have a verified diagnosis that supports a need for home dialysis, and the treatment plan must meet the established guidelines for end-stage renal disease. To support the medical necessity for home dialysis, the medical record should reflect several items. First, it should document the patient has a confirmed diagnosis of end-stage renal disease and that the dialysis is medically required to manage this condition. It should also show that the physician or qualified non-physician practitioner has carefully evaluated home dialysis and determined it to be an appropriate treatment option. This includes consideration of whether the patient can safely perform dialysis, either independently or with assistance, as well as whether the home environment is safe and suitable, and whether the patient's overall health status supports treatment at home. In addition, the record should reflect that the patient and designated caregiver, if applicable, has successfully completed home dialysis training and has demonstrated the ability to carry out treatments as prescribed. Ongoing monitoring is also essential. The patient should be followed under an individualized plan of care that includes regular monitoring and reassessment to ensure that home dialysis continues to be a safe, effective, and clinically appropriate over time. Finally, all supporting documentation needs to be consistently maintained in the medical record and made readily available for review when necessary. All relevant medical records should be available, including face-to-face notes, progress notes, complete assessments, lab results, training documentation, and the plan of care. These documents should support both the decision to start home dialysis and the continued use of this treatment for end-stage renal disease. Before we begin reviewing some claim examples, I'd like to briefly point out two common denial reason codes we see with home dialysis claims. Familiarizing yourself with these codes can help pinpoint recurring issues and improve documentation practices in the future. And I did include a link on the bottom of this slide so you can actually see what these codes mean in detail. So the first reason code is GBB02. And this code indicates the documentation submitted was incomplete and or insufficient. Essentially, this means that the provided information did not meet the necessary requirements for the claim to be processed. This can involve missing forms, unsigned notes, or incomplete clinical information. In the case of home dialysis claims, it may also include insufficient documentation to support a full calendar month of services was provided, or lack of evidence showing that the dialysis facility monitored a self-care patient at least once every 2 months. To address issues of incomplete or insufficient documentation, thoroughly review the submission guidelines to ensure all required forms and clinical notes are included and fully completed. Confirm all forms are signed, dated, and contain all required information, including detailed clinical notes outlining the patient's condition, treatment, and response to therapy. Additionally, ensure the documentation matches the billed services and procedure codes and is submitted within the required timeframes. The next denial reason code is GBC02, which represents that the documentation submitted does not support medical necessity. In other words, the records fail to provide adequate justification for why the treatment was necessary based on the patient's condition or established clinical guidelines. To resolve this, ensure that documentation clearly supports the medical necessity of the home dialysis using recognized medical guidelines and evidence-based practices. Include comprehensive clinical notes detailing the patient's kidney function, dialysis, diagnosis, medical history, symptom severity, relevant laboratory findings, prior treatments, and response to therapy. Provide a clear rationale for why dialysis is the most appropriate treatment option considering the patient's specific condition. Also confirm that the correct dialysis procedure codes are used and ensure the documentation is complete, accurate, and aligned with medical necessity criteria to minimize the likelihood of denials. To help minimize the risk of denials, it's important to ensure all documentation is accurate, complete, and submitted on time. This includes provider orders, progress notes, treatment logs, and clinical documentation that clinically supports the medical necessity of the services provided. By taking the time to ensure documentation is thorough and timely, many denials can be prevented before they occur. And I just want to take a look at one of the questions. So the question is, how many days of, this is a question in our chat, how many days of peritoneal dialysis and how many days of HHD patient can miss for a provider still to be able to bill 90966, as I couldn't find any numbers in the guidelines. And there actually isn't a numbers of how many days per se. The guidance for that one is whether they have completed the face-to-face visit and whether they completed the complete assessment. If they have less than 30 days or 31 days or 28 for February in that month, and it's only a partial month that they've received it, but they've received that face-to-face visit and they've received that complete assessment, they can bill the entire MCP. Otherwise, if they have not completed both of those, then it would be a per diem basis billing. Okay, so let's move on. I don't see any other questions in the chat right now, so let's move on. So now that we've reviewed the documentation requirements for CPT code 90966 and common denial reason codes we often encounter, let's take a look at some claim examples. And I've included two examples, one with all the necessary documentation for CPT code 90966 home dialysis, and another that's missing certain required components of documentation. And as a reminder, since we can't actually see the patient, it's important that all required documentation is submitted to assist us with reviewing the claim. So our first example is claim number 1 with a date of service of January 1st, 2025. So for this claim, all documentation requirements for CPT code 90966 home dialysis have been addressed. So we're going to now take a closer look at each component of documentation used in the review process, and I will point out key findings within the patient's chart. So on this first page, we can see the monthly face-to-face note. Face-to-face note. So this face-to-face visit was performed on January 23rd, 2025. So now we're going to take a look at some of the information that was included in this visit note. So the physician documented that the patient's medications and labs were reviewed during this visit. And the list of current medications is listed under the home medications section of this note. So at the bottom of page 2, the physician documented the patient's vitals were measured in clinic. And a list of vitals obtained during the patient's previous visits was also recorded. In the middle of this next page, we can see additional documentation about the patient. In the treatment assessment section, the physician noted that the patient's blood pressure was under control and no changes were indicated. The fluid assessment section reflected that the patient's fluid status and weight gain were acceptable with no changes indicated. The dialysis order or prescription is next. It includes details such as type, frequency, start date, and additional instructions to ensure safe and effective administration in the home setting. Per the adequacy assessment, the adequacy target was not met. The patient's K over T was recorded, KT over V, sorry about that. KT over V was recorded as 1.8 for January 3rd, 2025, 1.81 for December 4th, 2024, and 2.21 for October 9th, 2024. Here you can see that a change was made to 2 manuals per day. The physician noted that the prescription compliance was acceptable, and a prescription change was discussed with the staff and the patient. The access assessment reported that the peritoneal dialysis catheter was in the left lower quadrant. The assessment stated that the access site was perfect, exit site looks clean, tunnel track was without signs of infection, and the fluid was clear. Per the anemia section assessment, the hemoglobin was at goal, the iron parameters were acceptable, the ESA dose was adequate, and no changes were indicated. The bone mineral metabolism assessment reported that the PTH, calcium, and phosphorus levels were controlled. Medication adherence was noted to be acceptable with no changes indicated. The nutrition assessment stated that the patient's potassium and albumin levels were controlled and no changes were indicated. Finally, the physical exam section reported that the patient was stable. The note was then electronically signed and dated by the physician for the date of the visit. Documentation related to self-training on peritoneal antibiotics can be found here on page 6. The details of the training were documented on this page, as well as the patient's signature and a witness signature confirming the training. The next few pages contain documentation of evidence of patient training. Pages 7 through 10 include the patient training checklist, which outlines the topics that were covered, which you can see right here. That the patient performed each task, they check that off, the date it was performed, and then the nurse trainer's initials. So we're going to scroll through those pages, and you can see each page has that information. And we're going to scroll to the bottom of page 10. So here at the bottom of page 10, we can see a certification stating the patient achieved the program objectives. Both the nurse trainer and the patient signed and dated the checklist. On page 11, it contains additional details from the nurse trainer about the topics taught and that the patient performed the tasks either independently or with assisted tools or notes. So here we can see that information. Pages 12 through 15 contain the peritoneal dialysis learning assessment completed by the patient, showing the answers selected for each question. So I'm going to scroll through that so you can see all the questions and answers. And we're going to scroll down to the bottom of page 15. So at the bottom of page 15, both the patient and the nurse have signed and dated this assessment. Pages 16 through 26 have the readiness assessment, documenting each module taught, its completion date, and any additional notes that were given during the training. So some of the topics include post-surgical catheter care, introduction to peritoneal dialysis training, emotional management, app use, kidney function, hand hygiene, exit site care, peritoneal dialysis exchanges, access and fluid management, solution strength, aseptic technique, complications, antibiotic administration, renal function, troubleshooting, medication management, emergency procedures, readiness assessment, transplantation, nutrition, telehealth, sample collection, waste disposal, and lab results. Pages 27, or rather, page 27 features a statement confirming that the patient and his wife successfully completed the training program on February 20th, 2023, and were competent to perform the peritoneal dialysis. The form was signed at the bottom by both the nurse, the patient, and the patient's wife. Finally, page 28 includes a statement confirming the patient successfully completed peritonitis prevention education, and the statement was signed and dated by both the patient and the nurse. The remainder of the documentation supported that a full calendar month of services was provided, and these records include information such as the patient's weight, the treatment delivered, nursing assessment of the exit site, and whether the patient had a bowel movement that day. So here we can see the documentation of services for December 1st through December 13th, then December 14th through December 26th, December 27th through December 31st, then January 1st through January 13th, January 14th through January 26th, and then January 27th through January 31st. So after reviewing this claim, it was determined that all required documentation for CPT code 90966 home dialysis was included in the submitted medical record. And this claim was ultimately cleared for payment processing pending any system edits. And I did see a question come up, so I just wanted to quickly address that. Let's see. It says the question is, does patient should document their weight, blood pressure, and other dialysis measurements every day if it's handwritten in the flow sheets in order to provide it to bill full month? Provider did educate patient as well as dialysis unit nurse, but patient still failing to document everything. The documentation, this is the documentation from the one I just showed was the documentation from the facility. Should the patient be documenting? Yes, the patient should document. However, this is the nurse going in, or the caregiver, rather, let me phrase that. This is the nurse going in, documenting what he or she saw when they provided the treatment. So the sheets I just showed you is a documentation from the facility, which is required to show that every 2 months that they've been following them and that they're documenting, they're giving the care each time that they deliver it, that each session is being documented. And I'm wondering if that is answering your question, but hopefully it is. If not, then just put a clarification in there for me. So let's move on to our next claim. So now that we reviewed the claim with all the necessary documentation, let's examine a claim that's missing some of the required documentation for CPT code 90966 home dialysis. So claim example 2 has a date of service of July 1st, 2024. And this claim lacks documentation to support the services were provided for a full calendar month and that the dialysis facility conducted self-care patient monitoring at least every 2 months. And again, just to go back to that question, the charts I just showed you showed that full calendar month showing the services were provided and that it showed that the dialysis facility is conducting patient monitoring at least every 2 months. Just to clarify those sheets. So again, back to this one. Both of these components, that self-monitoring every 2 months and the full calendar month of services, are required for billing CPT code 90966. All other components were submitted with this claim. So let's review the claim and the submitted documentation in more detail. So on this first page, we do see the face-to-face monthly note, and the physician conducted the face-to-face visit on July 11th, 2024. So we're now going to review some of the information documented in this visit note. The physician reported that the patient's medications and labs were reviewed, and a list of the patient's current medications are noted. Next, we find the patient's vital assessment, and the vitals were measured in clinic. In the treatment assessment section, the physician documented the patient's blood pressure was controlled with no changes indicated. According to the fluid assessment section, the patient's fluid status and weight gain were recorded as acceptable with no changes noted. Next, we can see the order or prescription for dialysis, and it includes details such as type, frequency, order start date, and additional instructions to ensure safe and effective administration of treatment in the home setting. The adequacy assessment reported that the adequacy target was met and prescription compliance was acceptable, and no changes were indicated. The access assessment stated the access was perfect. An acute infection was noted. The exit site had erythema. The tunnel track showed no signs of infection, and the effluent was clear. Per the anemia assessment, the hemoglobin was at goal, the iron parameters were acceptable, and the ESA dose was adequate. No changes were indicated. And right here we can see the patient has an active order for iron sucrose PRM. The bone mineral metabolism assessment reported the patient's PTH, calcium, and phosphorus were controlled. The patient's adherence to bone mineral metabolism medications was noted to be acceptable. Per the nutrition assessment, the patient's potassium and albumin were controlled and no changes were indicated. Under the physical exam section, it was documented that the exam was performed and vital signs were reviewed. The visit note was then electronically signed and dated by the physician for the date of the visit. On the next few pages, we have documentation of the training provided to the patient. On page 5, it includes a statement confirming the patient successfully completed the peritoneal dialysis training program. He was deemed competent to perform home dialysis on January 22nd, 2022. And this statement was signed and dated by the nurse, the physician, and the patient. Pages 6 through 11 provide an overview of the training content, including the topics covered, documentation of the dates when the skills were successfully demonstrated, so we can see the date here and that was verified here, and any additional notes relevant to the training process. Some topics of education included peritoneal dialysis training, emotional management, catheter care, app use, fluid management, complications, medication management and sample collection, troubleshooting, infection prevention, peritoneal dialysis and diabetes, emergency procedures, readiness assessment, nutrition, telehealth, and sample collection. The last few pages include documentation for services provided during the specified calendar months. Page 12 includes the flow sheet showing documentation for November 2nd through November 21st, 2024. Page 13 includes a flow sheet showing documentation for November 24th through December 9th, 2024. Page 14 includes a flow sheet showing documentation for December 11th through December 26th, 2024. And page 15 includes a flow sheet showing documentation for December 28th through December 31st, 2024. However, the documentation does not reflect the treatment for the date of service under review, which is July 1st, 2024. Now let's discuss what was missing from the documentation submitted. The flow sheets sent are for November and December 2024. However, the date of service under review was July 1st, 2024. The provider did not submit documentation to support the service for the date of review. Therefore, documentation supporting a full calendar month of services was provided, as well as evidence of self-care patient monitoring by the dialysis facility at least every 2 months could not be validated. This claim was missing these two required components of documentation and therefore did not contain all the required documentation to support the services as medically reasonable and necessary. According to 42 CFR section 494.100B2, the dialysis facility must retrieve and review complete self-monitoring data and other information from self-care patients or their designated caregivers at least every 2 months. Had these components of documentation been addressed, a different conclusion regarding medical necessity may have been reached. Home dialysis is a key part of managing end-stage renal disease. CPT code 90966 covers the physician's monthly oversight of these at-home treatments. Providers must maintain comprehensive documentation, accurate billing, and follow established guidelines to ensure claims reflect both high-quality care and payer compliance. So as a recap, during today's webinar, we reviewed documentation requirements, explore common denial reason codes we encounter with home dialysis claims, and provide documentation examples related to home dialysis. This slide includes helpful resources that you can refer to while viewing the presentation, including the Medicare Benefit Policy Manual, Chapters 11 and 15, the Medicare Claims Processing Manual, Chapter 8, 42 CFR 494.100, and the WPS resource Home Dialysis Services. Please refer to this slide as a reference when reviewing the presentation, or if you'd like additional information on home dialysis services. We are now at the end of the formal presentation. Please remember, if you have any questions, please put those questions in the chat. And if we don't get your questions today during the presentation, we will follow up with you after the webinar. So let me take a look at some of the questions we have. So Carrie has asked, does training documentation has to be sent if we are billing a 90966? And yes, the documentation showing that you have done your training with your patient does need to be sent, so you can prove that you have done it, that you have fulfilled that requirement of training. And I know sometimes it might be several years prior, and you can see in those examples it was several years prior, but yes, send your training documentation helps validate and provide that complete picture that you have provided all elements. Let's go to our next question. In your provider note example, where do you see the provider oversight and involvement in the plan of care? Where are you looking in the notes to support this requirement? And they're looking at the overall complete record. And I did show you the information with all the different components in there. And as you can see, as you went through the note, you can see all that information of their oversight and involvement in that plan of care, such as what the access assessment said, the nutrition assessment. That is the example of showing that oversight and involvement. Okay, give me a second because this one had several questions in there. Okay, answered that already. Okay, the question is it correct that 90966 can be used when the patient is under the provider's medical supervision, even if individual treatments are missed and the provider mentioned in the notes that the provider was available full month, regardless if the patient provided flow sheets? That's a multi-leveled one, so let me answer that one. You can bill 90966 if they are under that medical supervision, as long as they're meeting those requirements. So it's whether you're going to bill the per diem basis versus the full month. So again, the full month needs to have that face-to-face visit and the assessment. If it does not have both of them, because they were not available for the full month, then it would be a per diem payment. And the second question, if individual treatments are missed, but the provider mentions in the note the provider was available regardless if the provider provided flow sheets. And the flow sheets do need provided. And that one, you need to document that they were given the treatment. But if they are not receiving the treatment, then they would not necessarily get the full month. The full month is with the assessment, it is with the face-to-face visit, and it is the patient is receiving the full month of treatment. So if the patient is not receiving the full month of treatment, I would document that. But if they are not receiving the treatments, then they would not be able to bill for those treatments. And I'm hoping that helps address your question. So if not, again, put that in the chat. And I do not see any other questions. Mary Sue, do you see any other questions in here?
Sorry, Jennifer, I was double muted. No, I am not seeing any additional questions have come in.
Okay, thank you. And again, if you have some clarifications or you have another question, just put it in the chat and we'll see if we can take a look at that. So please take a moment to complete the survey and share your feedback. We use your feedback to develop topics for future education events. In a few minutes, you will receive an email thanking you for attending, which includes your certificate of achievement and a link to the survey. If you need contact hours for continuing education, they will also be in the email. If you don't see it, check your spam folder. If you called in, email us at wps.gha www.education@wpsic.com with the webinar name and phone number, and we will send you your certificate of achievement. If you think of any additional questions after today, you have 7 days from today to submit them. Send them to that educational email address that we just gave, which is wps.gha.education@wpsic.com, and put the title of this webinar in the subject line. However, if you have claim-specific questions, please direct those questions to our customer service department, as we don't have access to your claim information and therefore unable to look up claims. Also remember, we cannot accept any type of PHI or PII via email. Finally, on behalf of myself, Mary Sue, and all of Provider Outreach and Education, thank you for attending today's webinar on exploring documentation for home dialysis. As a reminder, this presentation will be posted as an encore presentation on the Training Center page on our website. Remember to take the survey with the link provided. And you'll also get a pop-up, and that pop-up again will be for the survey. And try to take the survey either through the link or try taking it through the pop-up. But we really do appreciate your comments, and we look forward to those survey comments and hope to have you join us for future events. You may now disconnect.